let me review the landscape a little of non-small cell lung cancer and see where we're heading today. Okay, so first of all, non-small cell lung cancer is the leading cause of cancer-related death worldwide. It's not the most common cancer. Breast cancer is more common among women, and prostate cancer is more common among men, but it is the most lethal cancer. And why is that? And the reason lies in this graph. Most patients are diagnosed at advanced stages. About 70% of patients with lung cancer will be diagnosed with non-operable disease or metastatic disease, and that obviously affects the prognosis, which is very, very, very poor. We are not even talking about 5-year survival in stage 4 lung cancer, and most patients are stage 4 lung cancer at presentation or eventually. And so what we can offer them most is systemic treatment. Okay, so let's see what systemic treatment do we have to offer them. Let's review the landscape of treatment, which was, I have to say, very dry until recently. If we go to the 1970s, we had nothing to offer them other than best supportive care, palliative care. When chemotherapy was first introduced in the 1980s, we had only platinum, which pushed the bar of survival just by a little bit, just by a few months. And when newer chemotherapy were introduced, we were able to give platinum doublet chemotherapy, which pushed the survival up to 8 months. Since then, chemotherapy hasn't done much. We found more tolerable chemotherapy, like pemetrexed, which doesn't cause hair loss. It's more tolerable treatment. And more easier regimens and supportive care, and we were able to give chemotherapy to a larger number of patients. In 2006, bevacizumab was first introduced. It was the first sign of some kind of targeted treatment in lung cancer. Bevacizumab is vascular endothelial growth factor inhibitor. It's monoclonal antibody that targets angiogenesis, and when added to standard chemotherapy, it could prolong survival by about 4 months compared to only chemotherapy. But that's it. We were at the range of 1 year survival with the best treatment, and obviously when we are talking about lethal diseases and masses of patients, we needed more. And this more came in the form of targeted therapy. So when we're talking about targeted therapy, or silver bullet, as Professor Yarden called it earlier, we are talking about 2 groups of patients with lung cancer. So the typical patients with lung cancer, we all know, are patients who either smoke or drink or do both, and they're usually a little elderly. But we also have a smaller group of patients, which we sometimes see, about 20% of the patients, who are relatively young, who are never smokers, who live healthy lifestyle, and you ask yourself, why those patients have lung cancer? What happened there? And the question and the answer to this question lies in the tissue. So in lung cancer, tissue is the issue. It wasn't the issue for many years. About a decade ago, we didn't really care what histology the specific lung cancer has. We only cared if it's small cell lung cancer or non-small cell lung cancer. The chemotherapy was a bit different. For small cell lung cancer, we won't offer surgery, and for non-small, sometimes you will. But as the years went by, we learned that histology does matter. First, it mattered for the selection of chemotherapy. We know that there are chemotherapies that are more suitable for adenocarcinoma, and there are chemotherapies that are more suitable for squamous cell, like pemetrexed, that is more suitable for adenocarcinoma, and gemcitabine, which is more suitable for squamous. We know that most patients are adenocarcinoma in histology, but later on, as the molecular pathology developed, we found certain targets mainly in adenocarcinoma, which we know now that we can give treatment to. So which target do we know? We know mostly targets in adenocarcinoma, mainly the EGFR and the ALK, and we're going to talk about both of them specifically. There are molecular alterations in squamous cell carcinoma as well, but so far we don't really know how to target them. Okay, so what target do we look for in adenocarcinoma? Obviously, the targets that we can treat. There's no point of finding a specific mutation in a gene that we cannot treat. We can only tell the patient, okay, you have this gene, what can we do about that? Not much. So the genes that we look for are mainly EGFR, which is found in 10 to 15% of patients with adenocarcinoma. The percentage are dependent in the cohort tested. There are different cohorts of patients, European cohorts, American cohorts, Asian cohorts, and the percentage is a little different. So EGFR, the second most common is ALK, which is mutated in 4 to 7% of patients. And there are other genes that are less frequent, like BRAF, ROS1, HER2, and MEK, which are mutated in about 1% of the patients. So let's start talking about EGFR. EGFR is the most common alteration that is found in non-small cell lung cancer. And what is EGFR? It's basically a receptor. It's part of family of receptors that is called ERB family of receptors. It was widely investigated by Professor Yarden. As he told you before, it has extracellular and intracellular domain, and it transducts signals of growth into the cells. And when it transducts signals more often, the cell grows and it can metastasize. So inside the EGFR, we have several mutations that we know that are more common. There are two common mutations. One is a deletion mutation in exon 19, and the second one, the second most common, is mutation in exon 21, mainly the L858R. And these two mutations are predictive for response to EGFR tyrosine kinase inhibitors, or TKI, as I will refer them from now on. And we know that for the other mutations, the response for EGFR inhibitors is far less prevalent. And for exon 20 insertion mutation, we know that we don't expect response with EGFR TKIs. So if a patient walks into our room, how will we know how to test him? So first of all, in Israel, we test everyone. I'm not sure if this is the right way to go, but if we have to choose the patient, who will we choose? So we know that patients with adenocarcinoma histology have more chance of having EGFR mutation. Women, for some reason, have more chance of EGFR mutation, and never smokers. That's the key factor of our patients. Patients who are never smoker or with minor exposure to cigarettes are more likely to have a specific mutations. And for some reason, Asian have higher prevalence. The chance of Asian woman who does not smoke to have EGFR mutation is in the range of 45%. Okay, so how do we diagnose it? And here, most cases, we need tissue. We need tissue. It can be pathology, it can be a cytology sample, but we need tumoral DNA, and we do PCR, polymerase chain reaction, in the tumor cells. We don't have to do it de novo. There are designated kits that pathology have that are FDA approved, and we can use those kits. Who do we check? We check all patients with adenocarcinoma histology. We always have surprises, but we also check squamous cell carcinoma if the patient is never smoker, or if there is mixed histology of both adenocarcinoma and squamous cell carcinoma. And why? Because we have treatment. That's the main reason, but also because EGFR mutation is a good prognostic sign. Those patients will probably live longer and respond better to chemotherapy, and that's a good thing to say to the patient. Okay, so what data do we have on EGFR inhibitors? The first trial was the IPAS trial conducted by Professor Tony Mok. He's a superstar in China. I can walk in the street without someone stop him, and that's because he made a huge revolution in the treatment of lung cancer. So he conducted the IPAS trial. The IPAS trial was a revolutionary trial conducted in Asia, and he took patients with stage 4 lung cancer who are never smokers or light smokers, and he gave them chemotherapy to one group, the standard treatment, versus Iressa, Gefitinib. That's EGFR TKI inhibitor. That's the first agent used. And he watched for the results of the treatment. At that time, when the trial started, we didn't really know the connection between EGFR inhibitors and EGFR mutation. We looked at EGFR amplification, we looked at all kinds of things, but we didn't know how to look for the exact mutations. So patients were not selected according to mutation in that trial, and the results were accordingly. There was overall similar progression-free survival and no overall survival, but when the results came, we already knew about the EGFR mutation, and patients were retrospectively randomized to EGFR mutation positive versus negative. And what this trial did show that patients with EGFR mutation responded far better to Iressa than to chemotherapy with higher response rate, higher progression-free survival, while patients with no EGFR mutation didn't respond to Iressa at all. So there's no point of giving EGFR TKI if you don't have the mutation. That trial was revolutionary. The concept of giving a pill once a day to stage 4 lung cancer was very surprising, and many people didn't believe this result, and so many trials followed the IPAS trial, like the optimal trial that was conducted in China, shows similar results with other agent of EGFR inhibitor, the erlotinib. And then they say, okay, all those patients are Asian. How about the European population? And then there was a trial conducted on Caucasian European population, the EUROTAC trial, conducted by Rosell. Again, showed the same results of very good response and increased progression-free survival to erlotinib versus the standard chemotherapy. But all those trials were not able to show increase in progression-free survival. We don't know how to explain that, because what we see in clinic is that those patients do live longer on EGFR TKIs, but we can guess that they got the treatment on subsequent lines of treatment. Now, another agent, the second generation EGFR TKI, afatinib, was irreversible inhibitor, which was tested both in Asia with the LuxLung-6 and worldwide with the LuxLung-3 versus the standard chemotherapy. The trial were designed the same with a little bit different chemotherapy, depends on the areas in the world. And the results were the same: increased progression-free survival, increased response rate, but no overall survival difference, as we can see. But when they did subgroup analysis of both trials of the LuxLung-3 and the LuxLung-6, and they stratified the patients according to mutation, they saw that for the specific mutation of EGFR exon 19 deletion mutation, which is the most common one, there was increase in overall survival of almost a year compared to the standard chemotherapy. And that's the first time where they show increase in progression-free survival, in overall survival with EGFR TKIs. And actually, all three drugs are approved and are recommended by the international guidelines, both NCCN guidelines and the ESMO guidelines. And there was some head-to-head trials of all agents, and they all show that the efficacy is overall the same. One other advantage of this treatment is very, very rapid responses. So if you look at the image on the left, this is an image that was presented by Professor Fred Hirsch from Denver, Colorado. In 2002, he presented a patient of his that responded beautifully to Iressa within 5 days, and no one actually believed that 5 days to basically almost cure cancer. That's something that is hard to believe. But then we saw that on our patients as well. If you look at the chest X-ray on the left, on the right, this is one of our patients. She was a professor in the Faculty of Medicine, and she presented with increasing shortness of breath. We diagnosed her with cancer, and she deteriorated daily. She was on the verge of intubation, and the results of the EGFR test were not ready yet, but we said, okay, we have nothing to lose. We need to start treatment. So we gave her, unlike the guidelines, I have to say, we gave her both chemotherapy and EGFR inhibitors, and the patient responded within days. From near intubation to where she could walk without oxygen within a week. It was an amazing response, and since then we became believers. Those drugs does not come without cost. All those agents have side effects, mainly diarrhea, which can be severe, and rash, which is mainly acneiformic rash, like the teenager's rash, and paronychia, which can be very, very irritating. The nails could be very inflamed and infected. This is something we have to monitor, and we have a specialized nurse that look after these patients. One thing we are afraid of is pneumonitis, because this is a potentially lethal side effect. Only 1% of patients, and of course far less where it's very clinically meaningful, but we have to pay attention to that. Other side effects are usually mild. And among the agents, the different agents, gefitinib, erlotinib, and gefitinib, there is different in the toxicity profile. Afatinib usually has more diarrhea and more paronychia, and gefitinib has more hepatotoxicity. So this is one other way to select which agent to use. So these drugs are very effective. They show high response rate. They prolong the progression-free survival, and overall well-tolerated, but every good thing comes to an end. And Professor Oden was talking about resistance earlier. The cancer is in constant evolution, and when there's specific pressure on the EGFR gene, the EGFR can change. And with EGFR patients treated with EGFR TKI, we find very interesting phenomenon. Most patients who develop resistance develop a unique pattern of resistance in the EGFR gene in a location of T790M. And those are 60% of the patients who develop the same mutation. There are other mechanisms of resistance, including MET amplification, and there is very rare subgroup of patients who actually develop small cell lung cancer after they progressed on EGFR TKI, but most patients develop the T790M. And this derived a very labored research which actually found a drug to target this specific mutation, and the drug is called osimertinib, or AZD9291, or Tagrisso, the commercial name. And when tested on patients who progressed on first-line EGFR TKI, it caused very, very impressive response of 66% in the initial trial, but in the later trial it was up to 70% of response. I remind you, this is second-line therapy. with many complete responses and prolonged duration of response. Now we can see that those patients responded very well, even compared to chemotherapy as tested in the AURA-3 trial. Even patients with brain metastasis, which is an important thing in EGFR mutated patients, since 45% of them will eventually develop brain metastases. Patients with brain metastases entered this trial, unlike many other trials, and they responded as well. We do see responses in the brain, and the brain penetrance of osimertinib is higher than the other TKIs. And there was something else new about the development of this drug, which was unique. In this drug, in the detection of the EGFR mutation, we know that we need tissue. So that means all those patients who progressed on EGFR TKI need a second biopsy, and biopsy is an invasive procedure. But the technology has evolved to a level where the pathologist can isolate tumor cell-free DNA from the blood and do the EGFR testing on this sample. That means patients can have, instead of biopsy, have a simple blood test and get EGFR results, which is amazing. In terms of side effects, this is well-tolerated drug, much more tolerated than the other EGFR TKIs. And we only see one other thing which is important, and that's QT prolongation, which can lead to arrhythmia, but that's very rare. It happens in about 1% of patients in grade 3 and higher. And of course, osimertinib is part of the guidelines for second-line treatment in EGFR TKI. One more thing we have to remember about patients with EGFR mutation who are treated with EGFR TKI, in the first line, if there's only one clone of one lesion of tumor that progressed, that means if the patient has, for example, multiple lung metastases and only one nodule has started to grow under the treatment, we can treat it with radiation or any other local measure and continue treatment with the same EGFR TKI. We don't have to change the entire treatment because we think this is a specific clone that had specific evolution, and sometimes we can treat it locally and extend the treatment with this specific agent. But if there is overall progression in multiple sites, then we need to change the treatment. So to summarize, for patients with EGFR positive, we find it more commonly among never smokers, among women. We can diagnose it with PCR on tissue or in liquid biopsy. If it's positive, we do recommend one of 3 EGFR TKIs, and when the patient progressed, we do a second biopsy, which can be solid or liquid, and if T790M is positive, yes, we do recommend treatment with osimertinib. Okay, let's move to the second target. The second most common target in non-small cell lung cancer is ALK rearrangement. The ALK is a certain protein that underwent some change that allows the different parts of the protein to come together in a little different configuration. It's called ALK rearrangement. It's mutated in 4 to 7% of the patient, and we can detect it by FISH, by fluorescence in situ hybridization, in a test that is called break-apart test. We have markers for 2 locations of the protein. If they appear together, then there's no rearrangement. But if they appear in a distance, like we do see here, a green signal and a pink signal which are far from one another, that means there is rearrangement. And this is the gold standard test, but we know today that we can also diagnose it with immunohistochemistry, which is much more simple and, of course, cheaper. So the story of the discovery of the ALK rearrangement is a very interesting one. Actually, the discovery came from Japan. There was a Japanese surgeon that operated on a 40-year-old patient who was never a smoker, and he told this pathologist, I don't understand why this patient has lung cancer. He's never a smoker, he's healthy, he's a young, healthy man. Why does he have lung cancer? Please check everything. So the pathologist was very thorough, and he did check everything. And he found a specific mutation that he knew from a certain specific lymphoma. And he looked at the literature, and he discovered that there is actually a drug in development for this specific lymphoma. And he said, okay, maybe it will work here. And so they acquired all the approvals from Pfizer to get Crizotinib, and the patient was treated with Crizotinib and responded beautifully. And that triggered phase 1 clinical trial with Crizotinib on patients with ALK rearrangement. It was conducted in Boston, and you can see huge response rate, very, very high response rate with Crizotinib. You can see the waterfall plot that for almost all patients, the tumor has shrunk significantly. And this triggered very rapid approval. It was the first drug that was approved based on phase 1 trial. The FDA granted accelerated approval, and we started using this drug. It has specific side effects. The main is pneumonitis. It's rare, but patients can actually die of pneumonitis, so this is the one thing we need to pay attention to. There are other side effects, such as hepatotoxicity, nausea, edema. They are usually mild, and there is very weird side effect of flashing in the visual field, which is very mild and usually at night, but we always warn the patient not to drive. After this accelerated approval, larger trials were conducted compared to chemotherapy. First, in the second-line setting versus chemotherapy, pemetrexed or docetaxel, which showed increased progression-free survival. And so the drug was approved for the second-line treatment, and then another trial, the Profile 1014, looked at the Crizotinib in the first-line treatment versus the standard chemotherapy, and also found prolonged progression-free survival and increased response rate, but no overall survival. And it's the same thing as we saw in the EGFR trials, no overall survival, but we do see survival benefit in clinic. Those patients were probably treated with multiple ALK inhibitors on subsequent lines. Our experience with Crizotinib, we have large experience with ALK rearrangement. We are always happy when we get the answer of ALK rearrangement, because we have so much to offer these patients. This is one of our first patients that was treated with Xalkori. She presented after progression on first-line chemotherapy with very large disease. She was very symptomatic. We started her on compassionate treatment of Xalkori, and a month later she did a CT scan, and we saw very, very nice response. This patient responded for a whole year on Crizotinib with very good quality of life until she progressed. But again, as in EGFR, resistance usually develops after a median of 8 to 10 months in Crizotinib, and we usually see progression most likely in the brain. The concentration of Xalkori in the brain is relatively low, so large percentage of the progression happens in the brain. But after Crizotinib, after this huge success of Crizotinib, there was vast research of ALK inhibitors, and now we have several other agents with better characteristic of the drug, with better side effects profile, with better brain penetrance, and we see very good responses in the brain. So the next line after Crizotinib is either Ceritinib or Alectinib. For now, this field is evolving rapidly. Both have very good activity in the brain, very different toxicity profile, and there are other agents in clinical trial, lorlatinib and sartinib, and recently brigatinib was also approved as second-line ALK inhibitor. So we also see in the second-line ALK inhibitors also, we see very good response rate. We see very high response rate with ceritinib, with alectinib. Those patients were treated with crizotinib. They progressed and they started second-line ALK inhibitors, and they responded again. Alectinib showed very good results in as second-line treatment, so they decided to figure out whether it can be used as first-line treatment. And so the ALEX trial was conducted that compared alectinib versus crizotinib in the first-line therapy, and the results were very, very impressive. The hazard ratio for progression-free survival was 0.47. We don't have the progression-free survival was not reached yet, and this will probably be the next first-line therapy. It will probably replace crizotinib as first-line therapy, and that's and we're really happy about that because alectinib has very good brain penetrance. So we will probably see less brain metastasis in this population. Unfortunately, when we do see resistance, it's not like EGFR. With EGFR, we had 60% of the patient developing the same resistant pattern, but in ALK, unfortunately, it's not the same. We have multiple mutation in the ALK. We have combined ALK and EGFR mutation. We can't distinguish specific pattern of resistance, and so we don't have any approved lines of treatments. We don't know if we can use a specific agent after crizotinib. We don't know what is better. So we basically use what's available for us and what is more tolerable for the patient, but we don't know if what's the best second line ALK inhibitor. Okay, and of course the ALK inhibitors enter the first-line treatment in the international guidelines, mainly the NCCN, and as subsequent treatments. Okay, so let's summarize. ALK inhibitors is ALK rearrangement is found in 4 to 7% of patients. We can detect it with FISH, but it's faster and cheaper to do it with immunohistochemistry. The first line is still crizotinib, but it will most probably be replaced by alectinib in the future, and the sequence of treatment is not clear yet. Since we have multiple resistance pathway. Other targets in lung cancer, let's talk briefly about the ROS1. It's mutated in 1% of the patients with non-small cell lung cancer. It's also detected same as ALK, it's also rearrangement, so it can be detected by the FISH break apart test or by immunohistochemistry. There is very good response to crizotinib like ALK rearrangement, but unfortunately we don't see very good responses to ceritinib and alectinib. It's not exactly like ALK, but we do have second-line treatment currently tested with lorlatinib, which is another agent which targets both ALK and ROS, and we hope to have better options in the future, but so far we only have crizotinib with, again, very, very high response rate to treatment when we detect ROS1, high duration of treatment. Those patients respond for over a year, of a median of over a year with very deep responses. Okay, and the last one, even more rare than ROS1, is BRAF. The same mutation as in melanoma occurs in 1% of patients with non-small cell lung cancer, and the treatment is the same as in melanoma. Combination of BRAF and MEK inhibitor, in this case dabrafenib and trametinib, demonstrated very good response in the first-line treatment of patients with lung cancer and BRAF mutation, and the NCCN recently put that in the guidelines, but it's still very, very early. You see the date, it was presented in September 2017. Those are the main targets that we have now, but we hope to have more in the future and provide targeted therapy which is, again, tolerable and easy for the patient. Okay, so let me say a few words about immunotherapy, and I'll continue talking about that later in the case. Immunotherapy is basically the main revolution in non-small cell lung cancer. Targeted therapy has revolution and a subgroup of lung cancer, but immunotherapy is applicable for much larger population of patients with non-small cell lung cancer, but we don't know exactly who yet, same as for other cancer types. So we talked about the inhibitor receptors of the immune system, and from those we know how to target mainly the PD-1 and the CTLA-4, but the ones that were tested more and are approved in non-small cell lung cancer are the PD-1 axis inhibitors, both the PD-1 inhibitors and the PD-L1 inhibitors, and we have several agents among the PD-1 inhibitor, the nivolumab, Opdivo, the pembrolizumab, the Keytruda, and among the PD-L1 inhibitor, atezolizumab and durvalumab. And let's review some of the data that we have on all of them. Now, we talked earlier about pseudo-progression. The oncology community was very excited about the concept of pseudo-progression. We know how to treat chemotherapy. We know that larger is worse, smaller is better. But then they told us, okay, if it's larger, wait just a little more, and then maybe it will shrink eventually. And they showed us examples in conferences where the tumor got bigger and then it got smaller because of the immune infiltration in the tumor. But our enthusiasm from the concept of pseudo-progression has decreased significantly. I personally analyzed the Israeli database of patients treated with immunotherapy and the Toronto database of patients treated with immunotherapy, and we found 1% of patients with pseudo-progression. And the question is it worthwhile to continue treatment beyond progression in the hope of pseudo-progression for all patients for the sake of 1%? And of course, with huge toxicity, both medical and financial toxicity, but we can talk about that later. And of course, let's remember that we do have the concept of hyperprogression. What is hyperprogression? Hyperprogression is characterized by a growth of over 50% of the tumor mass in the range of less than 2 months. It's a new concept. It was first detected in head and neck cancer, but then a recent work that was presented in ESMO in September 2017 talked about hyperprogression in non-small cell lung cancer, and they show a rate of up to 16% of hyperprogression. So if we have 1% of pseudo-progression and 16% of hyperprogression, I think it's better to stop treatment if we see sign of progression. In terms of side effects, we talked a little about side effects, all the itis, but it's important in lung cancer to talk mostly about pneumonitis. Pneumonitis is potentially fatal, especially for those patients who are, most of them has COPD, most of them are smokers, and some of them got radiation, which can increase the risk of pneumonitis. So this is something we need to monitor more in patients with lung cancer. So, Dr. Pe'er was talked earlier about not having a good biomarker for immunotherapy in GU malignancy, and I'm afraid we're at the same status in lung cancer. We know how to detect PD-1, and we do test for routinely for PD-L1. But as we will see in the lung cancer trials, PD-L1 was not found to be a good predictive. We can try mutation burden, because we know that lung cancer is at the top of the malignancies with high mutation burden. So we can try and detect that and try to use it as a predictive biomarker, but this test is not easy to do in routine practice. So far we have no good biomarker, so at least in the second-line therapy, we give immunotherapy to everyone. So let's see what data do we have. The first trial that was done in immunotherapy in lung cancer was done in the second-line therapy for nivolumab versus the standard second-line therapy of docetaxel, and it showed very good results and was published in the New England last year. So we saw in this trial that nivolumab versus docetaxel increased survival by 3 months. It has a very long duration of response. So if patients are responding to nivolumab, they will respond for sometimes for years. We see very long progression pattern compared to patients who responded to docetaxel that are expected to respond only for a few months. But what was strange, that we have overall survival, but we don't have progression-free survival. That means we see patients are progressing, but they do have overall survival benefit eventually. And when these trials stratified patients by PD-L1 status, and we found something strange. Whichever cutoff of PD-L1 that we looked at, we saw that above this cutoff, the nivolumab was more effective with high progression-free survival than chemotherapy, and below this cutoff, chemotherapy was better. So we don't really have cutoff of PD-L1 to use, not 1%, not 5%, not 10%, and so this drug was approved for the second-line treatment of lung cancer with no biomarker. We basically give it to everyone. And what was interesting is the side effect profile. The nivolumab not only prolonged survival, but it also caused much less side effects compared to docetaxel. We see grade 3 adverse event in 54% of patients with docetaxel versus 10% of patients with nivolumab. And this is a repeating pattern in all trials of immunotherapy. So after this very successful trial, there were two other trials that were done in exactly the same pattern, the immunotherapy versus docetaxel in the second-line setting with 2 agents, with atezolizumab in all comers, and with pembrolizumab, Keytruda, again in the second-line setting. And those trials showed exactly the same thing. There was overall survival benefit of 3 to 4 months in those trials. There was no progression-free survival benefit, and there was no correlation with the PD-L1 status. And all trials showed much better toxicity profile of immunotherapy, and we can see that, but there was higher immune-related adverse events, mainly pneumonitis that we're very concerned about in patients with lung cancer, about 1% of patients in the immunotherapy group. So basically, as a second-line therapy in non-small cell lung cancer, we can give either agent. We can give nivolumab or atezolizumab or pembrolizumab as second-line treatment. In Israel, we use mostly nivolumab. We have very good experience with nivolumab. And we recently summarized this data and noticed that we don't really find a clinical characteristic as a predictor for response other than performance status. So patients with good performance status respond better, and patients with bad performance status perform better, which is not new and applicable for all therapies, basically in all malignancies. So we have immunotherapy in the second-line treatment, but can immunotherapy become the first line of treatment if it's so effective? Why not use it first? Why go with chemotherapy before? So there was one trial that took patients with PD-L1 of 50% or higher and gave them pembrolizumab, Keytruda, versus chemotherapy. And this trial showed increased survival with hazard ratio of 0.6 and very good toxicity profile. And in this trial, unlike the second-line trial, there was also a progression-free survival advantage. And so this is now the first-line treatment for patients with PD-L1. That means when patients come to clinic, we first check for PD-L1. We also check for molecular alteration, and if we can, if the patient is not symptomatic, we don't start treatment until we have PD-L1, because we know this way the patient can enjoy immunotherapy instead of chemotherapy. Okay, we can also see better toxicity profile with far less grade 3/4 side effects, but obviously, again, immune-related side effects, mainly pneumonitis. But can we use it in combination with chemotherapy? The logic say that we can, because we are trying to induce immune response, and chemotherapy can decrease the immune response. Will it be beneficial to combine those together? And surprisingly, the answer was yes. A trial called the Keynote 021 that combined pembrolizumab and the standard chemotherapy versus the standard chemotherapy. We don't have the full results yet. It's an ongoing trial, but we do have much higher response rate. If the response rate to standard chemotherapy was 29%, which is overall pretty high for chemotherapy, the response rate for the combined immunotherapy and chemotherapy was 55%, which is very, very impressive. There was also progression-free survival benefit, and this combination was approved by the FDA, but not yet registered in clinic. Okay, so what's next? Next, we, as Dr. Pe'er said, we're trying to test combination of both chemotherapies, immunotherapies, of PD-1 axis and CTLA-4 axis, and all of those with chemotherapy, and hope to get higher response rate. We are looking at immunotherapy in the adjuvant setting, see if it can increase the cure rate after surgery. And I think we're heading toward a very exciting future. Thank you very much.
Thank you, Dr. Moskovitz, for this excellent and comprehensive overview of the issue. Thank you. Вопросы, пожалуйста, доктор Пе'ер, прошу вас. Dr.
Thank you also for the excellent presentation. Concerning first line in lung cancer, if we have choice between PD-L1 inhibitors and EGFR positive, ALK positive, and the patient is very, very symptomatic. We know that immunotherapy works a little bit slower than EGFR, and you saw the example of dramatic response to gefitinib, for example. So wouldn't it be better to start as first line TKIs, EGFR or ALK, of course, and keep the PD-L1 for second line?
That's an excellent question. So if the patient has EGFR mutation, I have to say, the chances of response to immunotherapy are very low. So it's either one. If the patient has EGFR mutation, start him with EGFR TKI. It can give better response, better survival. Even if patients with EGFR mutation has high PD-L1, they are not expected to benefit immunotherapy as they benefit EGFR TKIs.
Thank you.
Еще вопросы, пожалуйста. Прошу вас.
Thank you. My question is about the predictors. You told us a few times that investigation of PD-L1 expression is not a best choice because it doesn't show correlation. But my question, is there any research about investigation both PD-1 and PD-L1? Because the expression of PD-1 on T cells may not be constant. It may be on just sometimes or not. Is it possible to investigate both this ligand and receptor to get some good predictor? And if there is such studies, who are they? Mm-hmm. Thank you.
Thank you. I think this is the $1 billion question. This is a very important question, and I think there is very high, very intensive research in this field. So we have several methods of testing PD-L1. Each drug company developed its own assay. They're all pretty much comparable. There were trial testing that, but they don't give us good enough answer. Mutation burden is closer to predict response, but it's very hard to do in clinical practice. There were several interesting trials like PET PD-L1. There was one trial that was presented in ESMO last month about PET scan, but instead of using FDG, the glucose, they use PD-L1 protein, marked radioactive PD-L1, and they were able to show the true rate of PD-L1 across the tumor and the response after immunotherapy. But that's very initial. It won't be in clinical practice soon. There is ongoing research about tumor infiltrating lymphocytes, the lymphocytes to neutrophil ratio, but nothing definitive yet. There is clinical predictor that is not very accurate, and that's smoking. We know that smokers respond better to immunotherapy than non-smokers. But that's also not a very good predictive, not the most accurate predictive biomarker. But this is ongoing. There's ongoing research with that. I hope that in a year or two we'll have a better answer.
Thank you very much.
Thank you.
Еще, пожалуйста, вопросы. Профессор Коттен, прошу вас. Please. Sorry. We have another. Just a minute.
Does it make sense to use Crizotinib in a neoadjuvant regimen before to perform an operation before the resistance develop?
It's a very good question because we will see very high response rate. If the patient is operable, we at least in Israel and worldwide, we don't do biomarker analysis for patients who are not stage 4. We do the biomarkers only for stage 4 patients, so we won't know if the patient has ALK mutation before. But if mutation analysis was done in earlier stages of the disease, so basically I think that could be a good idea, but we don't have enough data to support that. But it will give very good response rate, and that's the main purpose of neoadjuvant therapy.
I mean, for tumors which are locally spreaded, and for these patients who are not operative on the day of diagnosis, but after that, who doesn't have metastasis but has locally spread disease. Does it make sense to make ALK mutations or other analysis for making them neoadjuvant?
Yes, it definitely makes sense. Sometimes we know that for oligometastatic disease, we can try systemic therapy and then consider local treatment in the form of surgery or radiation if the disease is stable and it responds well to treatment. So yes, we don't have a series of patients to support that and see the long-term results, but yes, it could be a good way to do that.
Thank you.
Thank you.
Профессор Готам, прошу
I
вас.
just would like to have a comment. I saw your last slide with the future thinking and exciting new trials. What I missed on the slide is the combination of immunotherapy and radiation. And I hope next week in the EORTC meeting in Zurich, maybe I'll hear there's something new, because it makes sense to combine radiation, even in the metastatic setting, as what I mentioned before, in situ immunization, and enhance the response by adding the radiation as producer of mutations. Also, in the local regional advanced disease, I am looking forward to seeing somebody that will do a study on the combination. I think a problem will be that you will use the immunotherapy only for the time of the radiation and not then give it a year. And I doubt if there will be financial support to do such a study for just limited time and see how the immunotherapy enhances the effect of radiation. But I keep seeing, even in the ESMO meetings, not much enthusiasm to combine radiation and immunotherapy for some reason.
Perhaps because of pneumonitis? The concern
I doubt
of
if it's
pneumonitis.
pneumonitis. I have some thoughts why not, because people are used to do targeted chemo. I mean, they don't think about the other role of radiation as a biological agent, very important biological agent in enhancing these responses.
I can say one sentence about the PACIFIC trial that may answer some of your question. Last month there were initial results from the PACIFIC trial, which took patients in the stage of 3B after combined chemoradiation and gave them maintenance durvalumab, which is the PD-L1 inhibitor. So there was no pneumonitis, which was the main concern in this study, and there were very good results with increased progression-free survival.
Yeah, but
so maybe it will come to earlier stages.
it's a different issue. I think, again, role of the immunotherapy, like we gave Erbitux radiation for head and neck, we give chemoradiation for other situations. I don't see, and I'm surprised not to see the combination of immunotherapy and radiation in the local disease or in the oligometastatic disease as enhancer of the response.
I agree. Maybe you should initiate a trial. I'll be happy to participate.
Yeah, right.
Thank you.
Есть еще вопросы, пожалуйста.
Спасибо. Будьте добры, скажите, пожалуйста, раньше в литературе писалось, что лечение немелкоклеточного рака легкого после гифетиниб применялся как таргетная терапия, как третья линия, после второй линии доцитокселом. Увы, принимаете его и в первой линии, если есть мутация.
I don't hear the translation. Maybe you can help me?
Еще раз. Раньше в литературе писалось, что гифетиниб принимался как препарат третьей линии, и особенно при бронхоальвеолярных раках. Они принимают его как первую линию или как вторую, я так поняла, с слайдов.
You're absolutely right. Gefitinib was tested in the second-line therapy, but currently the IPAS trial was done as first-line therapy, and the NCCN guidelines approve it in the first-line therapy. All the TKIs were initially approved in the second-line therapy after chemotherapy, and only in recent years, after a lot of arguments, they moved to the first-line setting. One of the arguments was that 40% of patients do not reach second-line treatment. They progress and die along the way, and there's very good response rate. So all the TKIs have switched to the first-line therapy, and osimertinib is currently the second-line therapy.
Спасибо.
Thank you.
Еще вопросы есть? Да, пожалуйста, вот еще вопрос.
Thank you for presentation. And my question is,
Секундочку. In English, so.
Yeah, he speaks English.
do you have experience for exchange immunotherapy, like if patients has first-line immunotherapy and no effect, and do you have experience to change to another line immunotherapy too, maybe another drug or like this? Immunotherapy to immunotherapy.
Yes, so actually I saw that it's done a little in Canada, not in Israel. For patients who progressed, who had slow progression, so they stopped immunotherapy, they gave some chemotherapy, gained some response rate, shrank the tumor just a little, and then used another immunotherapy. Not because they thought the first one was wrong, only for availability issue. I've seen it done. Those patients remained stable for a while, but I can't give you long-term data because it's still early. But basically, we don't know if changing from PD-1 to PD-L1 or vice versa can give better results. We do know that combination of different immunotherapy, like PD-1 axis and CTLA-4, can give higher response rate, and sometimes we use one after the other, but that's not evidence-based data. What I do know that if someone had immune-related side effects such as pneumonitis, which was severe after one immunotherapy, then I won't dare, maybe some people will, I won't dare to give him another immunotherapy because I think I will risk reactivation of the same side effect.
Thank you.
Thank you.
Question
Yes.
about second-line afatinib without checking the mutation. We know for erlotinib, you don't have to check the mutation. Is it a class effect? And the question applies to smokers and non-smokers.
Yes, so many years EGFR TKI were considered standard second-line therapy. So the second-line therapy was docetaxel or pemetrexed or EGFR TKIs that were tested versus best supportive care. So the trial that looked at erlotinib in the second-line setting with no EGFR mutation was tested versus best supportive care. So they reported that given erlotinib versus nothing prolonged survival by about 2 months. Since then, there were several other trials comparing erlotinib and gefitinib and afatinib, and they all found some effectiveness. Today, in the era of immunotherapy for patients who are smokers who don't have the mutation, for sure, I would choose immunotherapy as the second-line therapy and not EGFR TKIs. It's less acceptable today.
And for
But,
non-smokers, it's an option, yes?
For non-smokers, it is an option because they have lesser chance of responding to immunotherapy.
In the
Yeah.
concept of beyond progression, second-line beyond progression, TKI beyond progression with a symptomatic patient.
TKI beyond progression is something that is acceptable. If there is clinical benefit, then for patients with the mutation and for patients without the mutation, if the disease is stable and only mildly progressive, there is the option of continuing treatment beyond progression because we do see different patterns of response. For chemotherapy, we use RESIST. We have the RESIST criteria, but the RESIST criteria was adapted for chemotherapy, not for TKI. But yes, it is an option for slow-growing disease if there is clinical benefit.
Thank you.
Thank you.
Thank you very much. Thank you. Мы немножко